HJ today in Chicago at the annual meeting of the American Heart Association. I'm Filippo Crea, Associate Editor of the European Heart Journal, and I'm sitting here with Professor Lafro from Children's Hospital in Boston, who has just presented a very interesting and innovative trial of atenolol versus losartan in children and young adults with Marfan disease. Our discussant is Professor Lefteriades from the States, who is a cardiac surgeon. Nobody's perfect. And I'd like to ask you about the background of your interesting trial.
So the Marfan trial was conducted under the auspices of the Pediatric Heart Network, and we sought to compare atenolol with losartan in young children and young adults with Marfan syndrome. For many years, the standard treatment in most centers has been beta blockers, like atenolol. And this was based on a study published in 1994 by Shores and colleagues, which showed that propranolol reduced the rate of growth of the aorta in people treated with Marfan syndrome. But more recent studies suggest that losartan, an angiotensin receptor blocker, might be better in slowing the aortic growth in people with Marfan syndrome. This is based on a mouse model of Marfan syndrome and small human series. So this was a randomized trial to compare atenolol and losartan in a larger group of children and young adults.
Can you summarize the results?
So we found that there was no significant difference between the atenolol group and the losartan group. We found that the drugs were both effective in reducing the aortic root Z-score, so that the severity of the aortic root enlargement was improved in both groups, but neither drug was better than the other.
Any comments on this trial, Professor Lefteriades?
Medical science has striven for decades to find a drug that could effectively treat aneurysm disease. There was great hope for losartan because of many years of innovative work done by Dr. Dietz and colleagues that laid the foundation for TGF-beta dysregulation in the mouse model. So there was great hope. But the study did not show any difference between those two drugs. I would just add that beta blockers are really completely unproven as a therapy for aortic aneurysm. The Shores trial has many limitations, and the other literature besides the Shores study is mixed, to say the best about medical treatment.
I think this is a very important issue. Let me understand. Did you find an improvement of some of the parameters relative to aortic enlargement or not in your trial? I mean, there is no difference because they are both to some extent good or because they are ineffective, as you are saying?
Our conclusion is that they're both effective treatments. If you look at the aortic root Z-score, which is a reflection of the severity of aortic root enlargement, the aortic root Z-score went down over the course of 3 years.
So not only it didn't increase, but it went down.
It went down, right. And we would expect, I mean, most of us clinicians who take care of patients with Marfan syndrome expect the Z-score to either stay the same or even increase over time. So the fact that the Z-score went down in both groups, I think is encouraging.
Well, now I want to understand, because you say they are both good, which means that perhaps this treatment can delay surgery to some extent. While your interpretation of it is slightly different, you say neither is good. What is the truth?
We have recently reviewed the literature on all medications used to decrease aortic growth, and it's mixed, really. There are trials that show benefit from beta blockers, trials that show no benefit from beta blockers. I really think the answer is unclear, and there may not be any benefit from beta blockers. That's not to say, Dr. Crea, that I'm not in favor of using beta blockers. I think that having a beta blocker on board may just limit that extreme hypertension that happens with severe exertion or severe emotion. It's that extreme hypertension that we have found is the trigger for aortic dissection. So I'm in favor of it, but I'm not convinced at all that it has benefit on the aortic wall and its growth.
So perhaps can just delay through some mechanism on hypertension the need for surgery. Do you think that this is the case? Very simply, if we have a child with Marfan, Should we give beta blockers or losartan or both to this child or not, in your opinion?
So, I mean, I think there are some important issues related to the dose of the beta blocker and angiotensin receptor blocker that the doses that we use in our trial. The doses of beta blockers that we used were much higher than most trials have used, and we used the way we up-titrated the drug was based on a response to the drug based on the heart rate. So we pushed the atenolol dose to achieve a 20% reduction in the average heart rate by a 24-hour recording. The SHORE study, which I think did show a decrease in aortic root growth in the treated patients, also used hemodynamic parameters by echo to titrate the dose to show a specific beta blocker effect. So I think that this study suggests that the dose that we select when using a beta blocker is an important issue. And I think some of the controversy or some of the mixed results in the previously done studies may be due to the fact that most of these studies did not use the kind of beta blocker doses
and with
that we
losartan,
used.
was titration based on which parameter?
So the losartan the dose of losartan was based on the FDA recommended dose for hypertension, which was the best that we could do at the time that we designed this trial in 2005, 2006. So the dose for losartan was 1.4 milligrams per kilogram per day. Maximum dose for adults 100 milligrams. So it's possible that a higher dose of losartan might show a better effect, but we didn't look at higher doses.
Well, after this clarification, would you give losartan or beta blocker to your children with Marfan disease?
Well, the purpose of the study was to show that losartan was better than a beta blocker, and it did not do that. That is unequivocal. I don't feel a need to put my young patients on losartan based on this trial. I think the authors, the investigators did a fantastic job with a well-powered, carefully thought-out study.
Large population.
Large population, more than 300 per group. But the aorta still grew about 1 millimeter per year, which is what we find in all our patients, in our 5,000 patients at Yale. They grow at 1 millimeter per year. And sometimes we have a negative study. Sometimes a mouse is not a human.
My last question, what about side effects? Because in everybody, but in children in particular, detrimental effects of drug on lifestyle are very important. And we know that beta blockers can worsen your lifestyle. What about this type of quality of life in your children?
So we look very carefully at that, both in terms of adverse events in both groups, as well as patient-reported symptoms. And there was, first of all, no difference between the two groups. So even though we used much higher doses of beta blocker than are often used, we didn't see that as a problem in the study. Both drugs were well tolerated and safe. There were very few symptoms that the patients reported that were very bothersome. So I think that the study reveals that these drugs are safe and can be used even in young children.
Well, in conclusion, I think that cardiac surgeons are still very important in treatment of patients with Marfan disease, and we have to struggle more with our medications in order to get even better results. Well, thank you very much for your participation.